Uh, Thank you for inviting me to talk to you today. And I should always note that I received a MARF grant early in my career that helped push things forward, so I'm obviously grateful for that. Let me just make sure that what I press. So I'm going to expand the talk you just heard a little bit on biomarkers and how we get there. Uh, I'm a surgeon, but I also do a lot of research on the genomics of mesothelioma. So I have a lot of conflicts because that's how I fund my research. And I have a deal whenever a company or someone wants to fund me for lung cancer because they want to collaborate with me on lung cancer research. I said, yes, as long as you also found a parallel mesothelioma research. That's what's necessary because we gotta do that. So let me expand a little bit about biomarkers. Biomarkers can be anything that's biological, that's in us. So, and it can be used for many things. So you can do early detection. You can take a population and screen them for the presence of whatever. So when your primary care doctor checks your sugar level and hemoglobin A1C, that's a biomarker for early diabetes. It can be used for, and when we see patients with plaques, they come to us, we follow them, we check mesothelin levels, we check CAT scans, because they're concerned it might progress to mesothelioma. So biomarkers can be used for early detection, for diagnosis, to figure out prognosis, which is how is the tumor behaving, to predict therapy for specific therapies, to do surveillance for recurrence, and to look for some genetic abnormality in your germline that might predispose people in your germline, in your biological relationship, to a disease. So those are most of the biomarkers, and it can be tissue, it can be blood, it can be tumor, it can be normal, it can be saliva, it can be a scrape. Pap smear is a biomarker. So biomarkers are all around us. It can also be in the blood. So you can do a whole bunch of stuff on the blood. You can look at the DNA, which makes up our chromosomes and our genes. You can look at RNA, which get translated from our chromosomes to make protein. So you can look at any of them. You can get CAT scans, and that can be a biomarker. It's called radiomics. Any radiological biomarkers is radiomics. And I'm sure there's stuff that I haven't thought about. But the police can use a biomarker when they swab, if you get in trouble, and they swab you and they check your DNA to see, and then they found that some relative did something bad many years ago. But hopefully that doesn't happen to anyone here. But that's a biomarker as well. So you just saw the slides about the three types of mesothelioma, and that's the subtype of mesothelioma is a diagnostic biomarker because it tells you that you have mesothelioma, or whoever gets it has mesothelioma. It tells you what type, so it's a diagnostic. Now, patients, if you don't treat anybody, patients with epithelial mesothelioma do better. So that's a prognostic biomarker. And then if you want to have immunotherapy, people with biphasic or sarcomatoids mesothelioma do better. So it's also a predictive biomarker. So that's a simple way to say that the same thing can be powerfully a biomarker. Now, I'm old, so I've been doing this for a long time. So how do I think about how to connect biomarkers and prognosis and therapy, etc. So I think a lot of stuff in medicine depends on the therapy. There's this circular argument. 100 years ago, the number one cause of death was infection. there was no antibiotics. There were no treatments. So more people were dying from infections and for the consequence of infection at that time than anything else. And people started staging the result of infection. So there is primary syphilis, there is secondary syphilis, there is tertiary syphilis. But now we have therapy for syphilis and for lots of other infection. So it doesn't matter what stage you are. We can give you antibiotics and cure most of you if you get an infection. So prognosis is related to therapy. If you have therapy for the condition, then things change. But we use staging because it produces the expected survival, the expected therapy, and we have recommendations for that. So that's the other side of the coin. And we believe, as you've seen in the previous lecture, that biomarkers can be helpful, and they are slowly, in many cancers and many other diseases, being inserted into the staging system to make them more relevant. Because you can have stage 4 cancer, but if you have a biomarker that tells you that you have a drug for that, well, you're not going to have the same effects as someone with stage 4 who does not have that. So that makes a difference. So that gets inserted. So as I think about prognosis, I think about the disease, how advanced is the stage. Then I think about the tumor separately. Does it have any particular markers for aggressivity or for benefit from therapy? So you can have stage 4 something, and if you have a drug for it, that stage 4 doesn't mean the same as if you don't. And then it has to do with the patient, because a lot of the treatments we use have toxicities. So, and so the question is, how well is the patient? How is the patient's nutrition status, the frailty, the other comorbidities, the age? How does that interact with the patient? So I've started over the last decade or so really distinctly separating that, because we and in many diseases have shown that your nutritional status is as significant in predicting how well you'll do as you stage. Now, this is a heavy slide. We published this about 9 years ago or 8 years ago. And this slide shows all of the genomic understanding of mesothelioma at that time. And we first sequenced the DNA, the chromosomes of 211 patients who had mesothelioma after we curated the specimens to make sure that mostly cancer represented. And we looked to figure out the prevalence of various mutations in them. And you heard about little mutations again from Dr. Soder. And we found, as being suspected, the most common mutations. And that led us to map the 5 or so pathways that the cancer can take to cause issues. And by defining the pathway is what's the metabolism or what's the function in the cell that requires these proteins. And once you understand the pathway, then you can see how the tumor interrupts the pathway at different places. But you also can see how you can overcome it with specific medicines. So you've seen that when we looked at MTAP and BAP1 and those mutations that you can identify kind of guide you to specific drugs for therapy. So in that sense, the mutations, the alteration in the tumor can either show you potential therapies, and with BAP, it can also show potential familiarity of the disease. On the right-hand side, it's the transcriptomic, and that's the RNA. So what we did, as many other people do with RNAs, the RNA is the messenger RNA. You all know about it from COVID vaccines, RNA-based. But it basically copies the gene and makes the proteins, and the amount of RNA in the cell differs in different cells, and the levels in cancer is different than the level of normal. And it can give you a certain fingerprint of the tumor. And what we found is if you look at those 211 patient specimens, that the tumor progresses from the epithelial part, where the cells are rounder and happier, to the sarcomatoid or mesenchymal part, which the cells are more aggressive, and that we call EMT. And that is a significant prognostic marker. That is the issue. And how it does that is one of the mysteries which we're trying to unravel in mesothelioma, and I'll talk about in 4 slides, that let us identify targets for therapy to kill it, to Achilles heel, if you will. Now, we talked about staging. This is the IASLC, so it's the International Association for for Study of Lung Cancer. And even as we are putting the next staging, and the staging system is what every institution uses to say, this is this stage, this is how we should do it. And we're on that committee, and I just wanted to show you in item 2.4.3 how these biomarkers are being used, because they're going to be very important for diagnosis, prognosis, and treatment. This is a study that we published a few years ago showing how we can use the biomarkers that we define to predict outcome in patients who have surgery in this kind. And that's how we identify people who do better with surgery, that being one therapy for mesothelioma, with surgery followed by chemotherapy. And you can see that the top curve, so this is what we call a Kaplan-Meier survival analysis. Let me see if I can figure out how to, which one is the, okay, I'll go back. I'm looking for the arrow. Oh, I found the arrow. So I can do it on one slide, not anywhere else. But so you remember I showed you that this is basically non-epithelial disease, and this is where the nutrition comes, the albumin. But the group that has the fewest unfavorable points does the better. So this is everybody's alive here at time 0, and you're looking at how people do up to 5 years. And you see the people who have these characteristics do much better at 5 years than the people who don't. So this is where biomarkers can have, in combination, prediction of prognosis of the patient from a specific therapy. Now let's go to something new and exciting. And we published recently, and we have it in press as well, a study of single-cell sequencing. And the way you do what's single-cell sequencing? When you look at RNA, you just take the tumor piece, you take a small piece of it, you grind it up, you make RNA from it, and you look at the RNA, and I showed you those 4 squares in various shades of blue. But what we have the technology to do now is to take the tumor and solubilize it and dilute it to a way that each separate cell gets coded by a QRS code, if you will. Simplifying it to use words that we can all understand. And then you multiply them by DNA sequencing, and then you when you sequence them, you can go back and see which are from the same generation of cells, and then you always know by their sequencing if they're cancer cells or non-cancer cell and so on. And that lets you look at the cancer elements separately from the immune elements, from the fibroblast elements, for all the elements but surround the tumor, because the tumor itself is made up of cancer cells and everything in it and around it. So it's not just tumor. And we're finding in many cancers, including mesothelioma, that those other cells inside can feed the tumor, make it bigger, make it smaller. And immunotherapy is basically a way to manipulate that. But there are other things to manipulate. But what was exciting is that as we looked at about 100 cases of single cells, we found that there is what looks like a new cell in mesothelioma. Because here is you're looking at everything I described from sarcomatoid to epithelioid, and there is a type of cell tumor here that's, we call it uncommitted because it can't decide whether to become sarcomatoid or epithelioid. And we found that mostly in biphasic tumors, but also in some sarcomatoid tumors and epithelial tumor. And I'll show you that in a second in the last slide. What's interesting is when you look at this slide that, like Dr. Suter showed, with all the stains that we currently use in mesothelioma, they all look the same. And then we stain it with the stain that we found based on this, and some get stained and some don't get stained. So it's not the pleomorphic or anything else, but it looks a little different in every case. Now, we did it at the protein level, and we did it at transcriptional analysis using RNA. And what I'm showing you here is what we call a core. And the core is, you take a needle of a certain size, you put it through the tumor, and then you put it in paraffin. And then you can slice the paraffin and make many slides. And you do it hundreds of times, so you can have on one slide 100 tumors. Now, this is mesothelioma. What do you think, Dr. Sutter? It's biphasic, or what do you think it looks like from there? Yeah, biphasic. I gave you a gimme. I'm just giving you a hard time. But all the pathologists, when you put two pathologists together, they're 80% the same. Yes, it's in the mail. I gave you something better. Spatial transcriptomic with 500 transcripts. So the 500 genes best expressed on single cell analysis are here. And we can select which we're showing, but these were the epithelial. These were the sarcomatoid, and these were the uncommitted. And you see how heterogeneous the tumors are. And you see even there, you can see some of these cells here. So now, unfortunately, cancer research is as important as it is, it's almost like peeling an onion. You peel a layer, you cry because you worked hard, and then there are lots of other layers underneath. And that's what we keep trying to do. But we believe we found a new cell in mesothelioma, and perhaps it may be a cell or a cell state. But this might indicate that there is an opportunity to treat another cell, because we right now are focused on either treated with chemotherapy for epithelial, immunotherapy for biphasic, but are we missing some of those cells because of the heterogeneity? So that's what's coming up in mesothelioma. As we peel the onion, we're discovering new things, and we're studying how we can treat these cells. So in conclusion, genetic analysis is becoming central in centers of excellence. From people you heard today, we do the genetic analysis routinely. Biomarkers do help define therapies. There are a whole bunch of specific trials for some of those biomarkers. Precision therapy is the future, and more exciting information is coming, and I thank my faculty for making things happen. So thank you.